Hello, hi there. I presume you can all hear me now. So my name's Hamid Sheikh. I'm a radiation oncologist from the Christie, and thank you for the privilege for talking to you today to present some of the work we've done with the lung MSCC pathway, the metastatic spinal cord compression pathway. So I'm a member of the lung team with 10 clinical oncologists, 8 medical oncologists at the Christie, so quite a big team. But I also cover acute oncology at Salford as one of my roles, and that involves seeing patients on the ward who have undergone core compression surgery and then are referred on to oncology for further management. And it did strike me, having seen a few cases of patients who never really got on to get heavy sort of going oncology treatment. I got quite concerned, and I felt I needed to look at this pathway, understand a little bit more about whether there's anything we could do to refine it, perhaps. It is a difficult group of patients because they're often comorbid and with very complex issues that overlay decision making. But we tried to untangle some of this in this audit that we did. And this was an audit retrospectively that we looked at in the Christie CWP, Christie Clinical Web Portal database, which was overseen by the MSCC coordinators and the service over here. And we identified 27 patients who had undergone decompression over a 6-year period. And I've just got the highlights of this audit. I didn't want to go through the whole sort of nitty gritty of it, but the highlights of this project that we did. And just to get, before I go to those survival results, just to say the background really is based on one landmark randomized controlled trial for spinal cord surgery, which is called the Patchell trial. The Patchell study that was published back in 2005 was the only really randomized controlled trial that really shifted management. And in that study, patients who had a range of different tumor types, but who were fit for surgery and had neurological function at the beginning, they were randomized to get surgery, decompression, plus radiotherapy afterwards, or just to have radiotherapy alone with steroids. And the primary outcome point was really looking at the rates of remaining ambulant or keeping good walking function. And the surgical arm did better. So the primary outcome was met in the sense that the ones that had surgery were more likely to remain walking. So that shaped kind of spinal cord surgical practice for years. And what the spinal surgeons want to know from us as parent team oncologists and for the sort of tumour groups to tease out is that, well, firstly, the case has been fully worked up and been through an MDT and endorsed to go down a surgical route. But secondly, that they've got a median survival of over 6 months. That's their ballpark figure. They want people to have a minimum survival of 6 months, hopefully more. And also they want people to be regarded as appropriate for SACT or systemic anti-cancer therapy. So that's those are their important criteria. So I'll just show you the results of survival in this project we had. The 6-month survival rate was just under 50%. So median survival was just under 24 months. 24 weeks or 6 months. And there's quite a range there. You see, some people did not live very long. So we looked at different factors to see which were the ones who were doing better, which were the ones who were doing worse. Some of the signals we found in the data, remember this is only 27 patients, so we can't start doing wide practice changing things just based on these numbers, but it gives us a feel for what the messages are. So the ACE comorbidity score seems to be a driver for worse outcome. And that kind of makes sense. Lung cancer patients are quite comorbid. So those patients who are quite comorbid perhaps ought not to have surgery and perhaps just best served having radiotherapy because not many of them will live very long. Also, we looked at the ones who did better and we broke it down by histology to look at the different groups. So the ones that had adenocarcinoma, you could see had a much better median survival, around 43 weeks. Squamous carcinoma did worse. And actually, when you look at it, you'll see that the population was enriched by some outliers. And that included people who were EGFR mutation positive, who went on to receive TKI therapy, in other words, targeted tyrosine kinase inhibitor therapy. Some patients went on to receive therapy against the ALK1 fusion translocation. And there's someone that had V600E mutation also who had a very good survival. So there was certain patients who did extremely well, who had undergone surgery, and these were the ones who had molecular drivers. So when we look at the availability of histology prior to surgery, it's quite an interesting question because we don't always have histology prior to surgery. And that's not necessarily criticism. It's sometimes because we can't get it, because the tumour is in a difficult place to biopsy, and sometimes the spine and the disease in the bones is the only thing you can get out to get a tissue diagnosis. But a lot of the time, it probably is possible, and there might be big chunky nodes in the mediastinum that are amenable to a biopsy. So in our case series, only 10 out of 21 of the new patients who presented with core compression had pre-op histology. And some of those were EGFR mutants. Four of them were mutants, went on to get TKI therapy again. But the message maybe being that we maybe need to be pushing that preoperative histology rate higher if we can do it, rather than just relying on surgical specimens. I suppose the other thing about surgical specimens to be aware of is they take a long time to process. They need to be decalcified to get the mineral content out. And then sometimes the actual tumour can actually degrade in quality, the tumour cells, and you lose tumour content. So you don't have enough then for molecular testing and things. So getting histology before was very important. Now, this was one of the key messages, this slide of this audit. Out of the patients we had, the ones that were brand new presenters with stage 4 lung cancer, not the ones who previously had therapy before, when we excluded the mutant patients, the ones who had the molecular drivers, so in other words, these are the patients that should be getting the conventional chemotherapy and chemoimmunotherapy, only 2 out of 16 went on to get chemo or chemoimmunotherapy, which, remember what we said at the start, that all these patients ideally need to be fit for chemotherapy, have a prognosis more than 6 months. Only 2 out of 16 went on to get that, which I felt was really too low. So some of the messages from this audit, clearly it's sort of theory generating. We can't sort of change practice overnight on this, but we were looking to try and get some key messages home, like how can we integrate molecular testing early in our pathway? Are there any ways we can do that? Can we improve the histology rate and get earlier biopsies? So rather than actually just send people off for surgery to have their histology, let's get it preoperatively where we can, even if that involves a CT-guided biopsy of the lung. Comorbid patients may be off to the surgical pathway early and go on to have radiotherapy. Perhaps this will help push up the chemotherapy uptake rate. Other things, the other way of looking at it is which are the ones that are more likely to benefit from surgery. The ones who have a molecular driver will live longer. They may then remain ambulant for longer. So they may be the sorts of patients better operated upon in the lung group. Patients who have got less comorbid, people where you simply can't get histology, which is understandable. Maybe you have to operate in those situations. Patients where the neurology is changing. So if someone is initially got no power loss, but then suddenly starts to lose power, they're a very sort of delicate situation. You may not have a window to get benefit of oncology treatment, so you have to therefore perhaps decompress those surgically. The ones with unstable spines, especially C-spine, where things can be quite unstable, and they may need a hard collar that can impact quality of life. So maybe those patients just have to go and get surgical decompression done. So the GM Pathway Board asked us to develop a pack, which would kind of an information pack that we could use across different disciplines of acute oncology and the lung team to try and get some cross-working, because this is clearly a specialty, an area where we need to bridge across different specialties, across different trusts, and work together and have better understanding about who does what. So we devised this little pack that I presented to the Pathway Board for lung and the Acute Oncology Pathway Board just a few months ago. And so we stipulated new referrals coming in for the MSCC. They all have to have an MRI scan. And we would like them ideally to have what's called the ESCC grading on the report, which is a way of us understanding how severe the core compression is. CT body needs to be done with contrast, and we want acute oncology nurses involved. So they're a key liaison between the MSCC coordinators and the parent teams in the local hospitals. We want them to be involved so they can kind of liaise with the acute oncology consultants as well. And referrals come in through the coordinator and through the on-call team at the Christie. This so-called Bilski grading, or the ESCC grading, is something that we find very useful as clinical oncologists, but sadly it's not yet accepted as a uniform standard of care across Manchester or even nationally. We were trying to promote this. It's still a work in progress to see if we can get some agreement to use this scale. So if they have early stage core compression, grade 1, 1A, 1B, or even 1C is regarded as impending spinal cord compression. Grade 2 and above is regarded as frank core compression. So grade 1C with neurology, in other words, with neurological symptoms, may well be treated by the on-call team urgently in terms of radiotherapy. But earlier stages of grade compression 1A, 1B would often be handed back to the parent oncology team to manage. And some of the surgeons may well also be whetting their appetite in some of these earlier stages of ESCC, where patients are still functional and walking. And these are the sorts of patients we think might benefit from expedited oncology involvement. So essentially, what we're trying to do is get everyone working together to break down boundaries and to use our acute oncology nurses in the peripheral trusts. So of course, their goal is to get people worked up, to get them under a parent team, to get the cup workup done when there isn't a parent team, but to liaise with the relevant sort of MDTs and get people through the diagnostics quickly. And liaise back with the sort of overseeing medics if there's change in any sort of situation. The MSCC coordinators are there to kind of make a coordinated decision with the surgeons, with the clinical oncologists, to decide if people are going to have the surgical decompression route or going to have radiotherapy or best supportive care even. But everyone's working together. And the MSCC coordinators, we've given them now this sort of tool for lung cancer to work with. So when they're getting a new referral, we would like them to get a detailed smoking history because that predicts for mutational status. People with a light or a low smoking history are more likely to have an ALK1 or EGFR activating mutation that predicts a better outcome. So getting an early smoking history is vital. Getting good comorbidity information. So the ACE comorbidity score is what we use at the Christie. There are other scores like the Charleston comorbidity score, but that helps us decide if someone is surgical or not. Getting a good neurological assessment done and knowing about spinal stability. Taking note if somebody is an Asian person or very young, because again, in lung cancer, those are the sorts of patients that tend to have molecular drivers, the EGFR or ALK1 or even ROS1 mutations, for which there are tablet therapies, and they do very well. So we set the bar around about 20 pack year history of smoking as being something that would be worth looking for a targetable mutation. Now, the EGFR mutation is the most common mutation there in patients who are light or never smokers, and there's a way of testing for it on peripheral blood. And if you do a peripheral blood test looking at the ctDNA, the circulating tumor DNA, you can extract the DNA and you can test for EGFR mutations in that. The yield is not always high because it depends on there being enough tumor cells in the blood, but if it's there and you get a positive hit, you've got a very quick answer. And so with this project, we've managed to now drive forward the availability of ctDNA testing for lung cancer in all sectors in Manchester, which is a really good achievement. So, and also we're looking to try and build up the relationships between acute oncology and the parent lung teams and the lung MDTs. So it's a collaborative approach, and this just shows that there are different points of entry to the sort of core compression pathway. There are some people already known to the Christie, already under the parent teams, where they will already have an opinion about whether they're surgical or not, and that's fine. That will probably be a quick decision. There'll be people who are coming through acute takes in the DGHs where acute oncology might get more involved. And there are people coming through the 2-week wait pathway, or probably we call the RDC pathway nowadays, the Rapid Diagnostic Centres under respiratory medicine. But everyone's working together in this sort of unified way, and it's to try and get everyone sort of liaising in the right fashion. Now, the ctDNA blood testing form, as I said, the kits are now all available in each different lung cancer service, and the pathway is owned by the lung cancer nurses in their clinics. Every lung CNS has now managed to set up their own service and have an ownership of where the forms are kept, where the tubes are kept, who takes the blood, and getting all the transport sent to St Mary's lab for it to be analysed. And if it's marked as urgent, you can get a turnaround for EGFR in 5 working days. So the ctDNA that's taken from the blood can either just be done as a fast track for 5 days for EGFR only, but if you don't mark it as urgent, it'll be done on the normal next generation screen pathway, and they'll give you a few other gene results as well for BRAF, KRAS, and MET, but that's 10 working days. So for this pathway, we're advocating using just the EGFR pathway, but still pursuing other means of getting tissue. So I'm not sure if that slide shows properly, but it's basically just a form there, which is the one that Matt Carter, who's our clinical scientist, has rolled out for all the peripheral trusts for the ctDNA testing. And he's happy to be contacted if anyone has early blood send with suspected lung cancer early in the cord compression pathway. So it's all about collaborative working and breaking down the boundaries, and this is what we were promoting at the pathway boards for Q oncology and the lung pathway board. So, for example, looking at the top left corner of this graphic here, so the MSCC coordinators will liaise with the on-call surgeons and the clin-oncs. They will create a handover list, and they will get the local medical teams to put a referral on patient pass because it's their responsibility to do that. Patient pass is the vehicle for referral that Salford use for getting somebody a surgical opinion. They will also liaise with the lung cancer parent oncology team if someone is definitely on a surgical pathway. So these acute oncology nurses have an important role now because, of course, they can then trigger ctDNA testing and get the lung CNSs to do that. And they can try and fast track patients onto a 2-week way pathway, get liaison with a lead lung cancer physician, get them on an MDT, and also liaise about changing neurology to the parent teams as well. So they have an important role. So it's not about saying this is our patient, you stay out. It's all about everyone working together and there not being a boundary there. And I preach to the chest physicians as well to say, look, they have an important role, not just to oblige with getting ctDNA done, but to oblige with rapid diagnostics, because essentially these are the guys who are motivated to do good diagnostic workups. They've got all the best tools. They've got eBus to do it, which is a really easy and nice tool to use for a fairly non-invasive biopsy in the chest. And they're also motivated and interested. So, if there's somebody with a renal cancer with a node in the chest, well, it might not be renal cancer. Just oblige and get a quick EBUS biopsy for us. And they took that well. The lung team accepted that. So, again, bringing everyone together and sort of building bridges between teams and getting the lung oncologists on board early and getting them thinking about, do I really want this patient to have surgery or do I think I can get them onto quick radiotherapy and systemic therapy quickly, maybe chemoimmunotherapy, which has a high response rate nowadays. So we devised this algorithm, which is, it can't be one size that fits all. It never can be. There are so many competing factors that help you make a decision. And of course, that's what the on-call teams are for and the MSCC coordinators for. And when someone is going down the surgical pathway, then of course we're trying to promote the lung oncologist for the sector to be a little bit involved as well. But as you'll see from this graphic, the vast majority of patients, the big arrow, will still be managed with radiotherapy because a lot of patients are comorbid, heavy smokers, lots of metastatic disease burden. So for those patients, we're still advocating on-call clinical oncologists get on and give them radiotherapy and take it through the MDT afterwards. But the ones we think that may well be a good case for surgery, we want the lung oncologist alerted early. And sometimes we may still not be able to stop people going down the surgical route for good reason. They may need to have an operation, as I said, for spinal stability. We can't get histology. Neurology is changing. But if they've got no weakness, they're fit, they are, and they may have a mutation, they may not, but we've got histology. These are the sorts of patients we might actually advocate. I'll give them radiotherapy tomorrow. We'll start a quick chemoimmunotherapy treatment a couple of days later, and we'll fast track their oncology pathway. And we may be able to drive up the treatment rates that way. And that's the whole sort of vision of this project. So really, to summarize, we're looking to break down boundaries, get everyone working together, streamline pathways, trying to drive up histology rates, trying to look for better prognostic groups, obviously exclude small cell because those patients go straight across to Christie for chemotherapy. We want to try and look for molecular drivers early, maybe by blood testing, get PD-L1 status done, which only can be done on tissue. And those that are likely to benefit from chemotherapy, we want to try and fast track them through to quick radiotherapy and chemo, rather than going onto the surgical pathway and then waiting 4 to 6 weeks for radiotherapy and sadly never making it to get chemotherapy after. So where we're up to now, the final steps now. So what we've done in this project is we've managed to break down boundaries. We've devised an algorithm. We've managed to get people working together across acute oncology, lung cancer pathway boards. Understand everyone has a role. It's not about these are our patients, you please butt out. It's about, look, we're all working together here. This is what the patient, what do we need to do to move it forward? Everyone work collaboratively. And so we're trying now to develop a fast-track referral pathway for a handful of these patients. I suspect there's only a handful per year. We're not saying there are very many, but maybe just a handful of patients who have preserved neurology, good function, good fitness, got histology, may or may not be mutants, but we want to spare them surgery. Let's get onto a fast-track systemic therapy chair. And at the moment, I'm working with one of our medical oncologists, Dr. Cove Smith, to try and develop like a referral form, like the small cell pathway, so we can actually make a quick referral to the Christie either for an expedited outpatient appointment or maybe even an inpatient transfer. So just to summarize, this to show you this quick document as well that With Insure have drawn up. There is a pathway document for emergency pathways for lung cancer already, surrounding things like airway management, coughing up blood, hemoptysis, small cell, SVCO. And we're hoping that we'll add in also core compression to this pathway so we can fast track referrals to oncology for this as well. So this is the final slide, just to say that these are the ideas that are being floated around amongst the lung group. We're looking to try and develop fast-track clinics and fast-track chemotherapy chairs, get PD-L1 results back quickly, as well as molecular profiling, and then make quick decisions to get people treated with chemotherapy sooner, rather than have an extended pathway on surgery and never making it to get chemotherapy. We're looking to try and expedite radiotherapy as well, so we can get maybe radiographer-led palliative radiotherapy clinics. But the Christie is in the process of looking at consultant radiographer models as well, so we'll have more access to fast radiotherapy. So in the future, we maybe end up asking the surgeon to operate on people maybe after having had chemotherapy, after failure, after control of from radiotherapy when they've progressed. But we may at least have people surviving longer who've had a chance to get chemotherapy. So that's the last slide. I'll stop there. And I hope that makes sense. I went through that quite fast, but I'm happy to take any questions from the audience. And I'm just going to have a read of what we've got now on the audience screen. So let's see, are there any particular questions? Oh, right. I hope you could see everything there in terms of the screen. Was everything being? I hope everything was being sort of broadcast across easily. I can't see any particular questions at the minute here. It's a work in progress, as I say. So once we have developed a referral form for metastatic spinal cord compression, it'll probably be very similar to the small cell lung cancer referral form for expedited chemotherapy, asking similar sorts of questions. And it will help us to triage patients to a chemotherapy chair and hopefully get them onto treatment fairly quickly and get their radiotherapy done very quickly as well. I envisage probably as I say, I reckon there'll be about a handful of patients, maybe 4 or 5 a year, who would fit this profile. But even if we save 4 or 5 patients a year from having surgery and never getting chemo, I think this project would have been worth it. So this is the vision, and I'm hoping we'll end up making a difference for the future. No other questions? So we're a bit ahead of time. So Oh, okay. Comment here. Not a question. Thanks for the presentation. Wigan Acute Oncology team will link in with the lung CNS to take forward. Absolutely. And essentially, this is it. It's all about trying to get you guys talking to each other, acute oncology talking to CNSs and lung, trying to understand what your local arrangements are for things like ctDNA testing, how you get people fast-tracked through to a lung physician, So the lung physicians are aware about all of this as well. They know that they are to oblige and help us to push things forward when they get a referral from acute oncology, and to get the ctDNA testing done quickly as well. Everyone is aware that they have that in their local trust now as well. So I appreciate Wigan doing that. And uh, for my sector, I know that we already have it set up for Bolton and for Salford. And hopefully the other sectors will be having dialogues as well with their lung nurses and lung physicians. So thanks for that comment, Ursula. So a comment from Anne in Leighton acute oncology. We've just started to link in with our lung CNS team and have started taking ctDNA bloods. Excellent. We've had two new MSCCs that have looked like lung primary, but sadly PS has declined post-radiotherapy. That can happen, of course. And so clearly it's about getting the right patient through to systemic therapy. And there will be a situation where these patients do have advanced disease. Some of them will have high burden of metastatic disease as well, and may not get onto having chemotherapy. But if people do have, for example, a molecular driver, they will all get a TKI therapy because it's relatively non-toxic and they get onto that very quickly. If they have a high PDL1 expression of, say, 90% or more, then that will predict a very good response to single agent immunotherapy without the risks of chemotherapy alongside. So it may well be, a good option to get on with that very quickly in somebody. But of course, their performance score still has to be between 0 or 1 or a good 2. So it's about getting a quick access to those pathways. But thanks for your comments there, Anne. Thank you very much. A comment from Sophie: does the ctDNA test negate the need for a biopsy? So no, that's not true. So it's an additional thing. That's a very good question. Thank you for asking that, Sophie. ctDNA testing is an additional thing. It has a high failure rate because it relies on there being a high circulating tumor cell burden in the blood, and not everyone has that, unfortunately. Some people may have only a few circulating tumor cells, and you may not be able to extract the DNA to do the testing for EGFR mutations. So it does not negate the need for biopsy. We should still always do one. But if you do have a positive hit, then it may negate the need for biopsy. But if it's negative, it does not negate the need. It means you still have to get a biopsy and rule out an EGFR mutation. And of course, test those other ones as well, like ALK1 and ROS1. And ALK1 and ROS1, the other mutations which are less common, can only be tested on a tissue biopsy, not on the blood. Another comment: I'm not aware whether ctDNA testing is available in Cheshire and Merseyside. This is something I will speak to the lung CNS about. Absolutely, yeah. So this is something to look at in your local trust to see whether this is something that can be set up. Certainly in Greater Manchester, we thought that everyone should have access to this tool. It helps the MSCC pathway, but also it helps the lung MDT globally, because it's not uncommon to have a 85-year-old whose performance score 2 to 3, and the chest physicians don't fancy sticking a needle in the lung and risking a pneumothorax. And so, if they're a lifelong non-smoker, you may well get a positive hit on ctDNA, and that 85-year-old may then get on to have a tablet therapy, whereas otherwise it'd be for best supportive care. So thanks. We just need to work on those things in local trusts. So Leighton is part of Cheshire and Merseyside, and it is available here. It's something we need to work through for all areas. But I was led to believe that Leighton did have it. That's my understanding as well. But outside of the Greater Manchester network, I'm not sure what your local centres will have. But I hope this talk will help stimulate a little bit of sort of ideas about setting it up locally in places that don't have it. It's not just for the MSCC pathway, where it can be invaluable, as you've seen, but also for those 85-year-olds, for the patients who are on the lung MDT, where it can be a very useful tool and get somebody onto a TKI therapy. They may then live for 2 to 3 years median survival, whereas with our therapy, they may not live very long, sadly. So thanks for those comments. Very useful comments there. Much appreciated. Perhaps have any other thoughts or any other questions? We've got 1 minute left according to the timer. Glad we got you going in the end with your comments. Thank you for those. Thank you. Thank you very much. Thank you for all listening, and hope you found it interesting and useful. Thank you very much.